think about all the varieties and ways that trauma can affect our clients and our patients that may not rise to the level of PTSD or post-traumatic stress disorder. Now, I want to give you a little bit of background and context for where I'm coming from. So I'm practicing all the time, full-time in San Francisco's VA's downtown community-based clinic. Now, this clinic focuses primarily on homelessness. It has a high percentage of patients who have chronic and severe mental illnesses. Our patients often have struggled for long periods of time with poverty, with issues of unemployment, substance use disorders, and most relevantly related to our topic today, with legal issues. Now, the VA is one of the largest healthcare providers in the world, and the VA treats over 1.1 million patients annually who are diagnosed with a psychiatric disorder. Well, we often hear about the Veterans Justice Outreach Program, and we hear about the other side of things, how Veterans Court and Treatment Courts develop. We have a little bit different timeline, and I just wanted to highlight some of those things because this will provide a little bit of that context that I was talking about. So the Veterans Justice Outreach Program in the VA system was started in 2009, and it's based upon some earlier research beginning in 1995, the mid-1990s, basically developed and based upon SAMHSA, the Substance Abuse Mental Health Service Administration's sequential intercept mapping, which basically looked at individuals and how they moved and had interactions through the criminal justice system. And it was kind of noted that individuals move through the criminal justice system in predictable ways. Based upon that, a reentry program designed and focused to help with individuals, particularly veterans, who are coming out of the criminal justice system was developed and started in 2007. As you know, this sort of correlates to the beginning of the first sort of documented Veterans Treatment Court in 2008 in Buffalo, New York. Now, based upon research that was going on between 2007 and 2009, the VA discovered that it already had informal connections to the criminal justice system through judges, prosecutors, social workers, and because of that, it initiated a formal Veterans Justice Outreach Program in 2009. So one of the things that we often talk about is sort of the medical model for that might be a little bit different. There are a lot of models for veterans treatment courts, and I'm just going to give you the San Francisco sort of perspective, and it might be a little bit different than other models, but this is the background is important. So we operate in the San Francisco's Veterans Justice Court, and I want to commend Judge Jeffrey Ross for his leadership, particularly because he's the kind of partner in this process that you'd really want to have. The San Francisco VA is comprised at the core, as I suspect, as most of veteran treatment courts are, based upon the role and work of social workers. They're really the ones who span all the intercept points for this intercept model, and they are there from shelters to detox facilities to courts to the medical clinic. I cannot tell you how much admiration I have and how valued my team members are. One of the longest serving individuals in our team is our nurse practitioner who provides primary care. And then myself as a forensic psychiatrist, we kind of comprise the dedicated members of the team. I'm actually the third iteration of a forensic psychiatrist who took over as the primary dedicated psychiatrist to this team 2 years ago. And one of the things that's often maybe a little bit different as well is we regularly attend pre-court conferences. So not just as forensic psychiatrists there in court during the conferences, but also intermittently the primary care provider, nurse practitioner goes. So of course, they're all same principles of coordination of care, and the main focus is really consolidation of providers, helping provide accurate diagnoses as well as treatment. So just a little bit more on our sort of medical model and how it sort of is different and informs kind of our perspective. So we're kind of guided by the traditional medical principles of promoting autonomy. And we can't have a coercive role. So everything that happens, it has to be on our patient's terms. Other elements are we have to promote beneficence, basically what we think is going to be best for our patients. And of course, non-malfeasance, do no harm is a principle that is a core element of our medical ethical kind of perspective. Now we have another core element, which is justice, and ours is a little bit different in the sense of not sort of procedural or substantive justice, but this comes from the perspective that we need to focus on individual patients and do what we think is best for them, while still balancing what we understand to be scarce resources. Now, one of the questions that's always brought up is, how do we think about treatment recommendations? And everything that we do comes in the context for a medical clinician, a modern medical clinician, under the sort of concept or rubric of evidence-based medicine. Now, evidence-based medicine utilizes what we think is the best scientific evidence, which would come in the form of randomized controlled trials. And we use this because randomized controlled trials help address two important aspects. One is the bias that might be inherent in the data that we're collecting, but also it removes us from a place where we might be confusing some of the variables, and we're going to get into this relating to PTSD. So we actually are measuring certain things. That's one of the reasons why our screening tools are not focused on maybe some of the social aspects relating to involvement with the Veterans Treatment Courts, but are more specifically targeted to screening tools for medical conditions. Now, in mental health, we have this concept of a biopsychological social model that also will help kind of inform how I'm talking about post-traumatic stress disorder. Now, two important follow-up points of this. The reason why I'm bringing this up is this helps support some of the logic, the ethical logic professionally, why we promote harm reduction. If we continue to not make interventions that we know could at least reduce some potential harms, then we could be basically allowing suffering to continue, which for us professionally is something that we cannot stand for. So one of the reasons why this sequential intercept model is important is that we see the interaction of veterans or patients with the criminal justice system as one of the social determinants of health, and that's one of the reasons why we're spending so much time and focus and energy on this. So PTSD, post-traumatic stress disorder in our patient population. Let's look at that. General population, our baseline level of post-traumatic stress disorder, we find about 6.8% of the general population has been diagnosed or has a diagnosis for post-traumatic stress disorder. Now, PTSD is often higher, found in higher rates in special populations. Think about refugees and military veterans are one of those special populations. Now, some studies have shown that there's a range, a wide range, but a significant number of our veterans coming back from OIF and OEF, that's Iraq and Afghanistan conflicts and wars, have and meet criteria for PTSD. So that ranges from 15, in some studies, up to even 35%. Now, generally, our veterans who are involved in the criminal justice system have higher rates, and we're going to talk about maybe some of those reasons and see how that plays out, particularly in the context of, at least from our perspective, in the San Francisco Veterans Justice Outreach Program. And for our program, we see that about 37% of our participants meet the criteria for PTSD, at least when we look at a 4-year period range. So let's take a step back, dig a little bit deeper, and kind of go through those elements of PTSD, and particularly let's talk about trauma. Trauma exposure is common experience. Particularly, it's a common experience for people who are involved in the criminal justice system. So I mentioned that about 37% of our veterans involved in our program meet the criteria for PTSD, or post-traumatic stress disorder. That's about in line with some of the national data that indicates about 39%, 40% almost, of justice-involved veterans can screen positive for PTSD. Now, this is lower, about a little less than half than all of the veterans who are incarcerated who have been exposed to trauma. And we're going to talk about maybe why all of them, or the number is lower in the sense of why is it not 80% or almost 90% of individuals who develop PTSD. We'll talk about that because we're going to go through actually the diagnostic criteria, and then I have some answers there. So in these two slides, this slide and the next slide, I just want to talk about some of the complex ways which trauma can intersect with our veterans and their lives. And the sources of trauma may predate and may occur during their veteran service, and may have also occurred after or following their service. And these various combinations basically describe a broad array of trauma exposures, and that's something I want you to think about and appreciate, particularly when you're thinking about who you want to be accepting into, or who you want to be targeting to bringing into your program. One of the things that we, just as a side note, in our program, we have actually very low bar, and we are not targeting particular diagnoses. Having been a veteran who's eligible for VA care is from our perspective on the VA side, is enough. So we're thinking about, while exposures, let's say one of these particular trauma sources, we think about traditional exposures, let's say to violence, domestic violence growing up, child abuse, might be understood as having the potential for kind of persisting into adulthood. Lower levels of severity of trauma, what we're starting to see, actually persist as well. So we're thinking about such issues as neglect. And neglect is an example of something that can persist and have lasting effects into adolescence and adulthood, similar to some of the more severe traditional trauma sources that we think about. Now, this kind of translates into potentially being targeted, and our soldiers, in particular, and our veterans, occupy one of those special categories, particularly relating to whether or not they're going to be a target. So combine these with all these other elements, gender, racial categories, religious groups, sexual identity, all of these kind of combine with then the cultural elements that are important relating to military trauma. Now, we think about traditional military trauma exposure. We think about combat. That's the issue. But the reality is, there are no front lines in modern warfare. The war zone has expanded in its experience. So we think about when we define kind of combat, it's radically changed. There's travel between bases exposes kind of convoys and individuals who maybe their specialty may not have been to be kind of forward deployed and with combats and weapons and taking fire and returning fire, yet that's exactly what happens with individuals. So also targeting veterans treatment, of course, for individuals with combat or individuals who we think may have been exposed to what we think are traditional, may kind of miss actually a large number and a significant number of potential clients and potential patients. Now, another aspect of this is the global war on terror. If there's a constant threat, if you're at a military base, or if you're just off duty but still a veteran, let's say in a foreign country, the global war on terror has really expanded the view and expanded the breadth in which we could be exposing, and combined with all these other elements, our veterans to the constant threat, constant stress, as well as potential trauma. Now, one of the things we're going to talk a little bit about, but I think it really should be reserved for a whole other discussion, is what happens to individuals, particularly veterans, who are the perpetrators of what we call sanctioned use of force. They're the ones who are returning fire, and they're the ones who see the results of this. This actually has a very particular effect upon individuals, and in my experience has been one of the more difficult sources of trauma that have persisted, particularly in my patients who are veterans of the Vietnam War. Another category that I think is really often overlooked but really needs to be focused in on is the role of military sexual trauma. A quarter of all female veterans and 10% of male veterans report, and this is just reported cases, having experienced military sexual trauma. And this is physical assault or threats, routine harassment. And the perpetrator, that's key about military sexual trauma, doesn't have to be a fellow service person, and the duty status, whether you're on duty or off duty, actually does not matter relating to military sexual trauma. So what is PTSD? A clinician really has to think about all of the combination of issues, the biological, the psychological, the social, historical context, and that helps inform the clinical aspects of what we're going to be seeing. So let's start with just looking at some of the first steps, the historical context for post-traumatic stress disorder. Initially, we used to call what we now understand as PTSD. Everybody traditionally talks about going back to the U.S. Civil War and talking about soldier's heart, frozen heart. And there was, in World War II, the development of the idea of shell shock. These are the issues that then developed into World War II, the concept of battle fatigue or combat fatigue. And this persisted actually into the Vietnam War era. We were seeing consistent behaviors for veterans who were returning from war zones that now we can look back were consistent with post-traumatic stress disorder. Now, PTSD as a formal disorder wasn't included in the Diagnostic Statistical Manuals until 1980, and then the DSM, the Diagnostic Statistical Manual 3, basically introduced that as a formal diagnosis. And this is relatively new because before there hadn't been the possibility of external stressors developing and causing sort of internal and persistent mental disorders. And we'll talk about some of the brain issues and some of the reasons why this makes sense. And in order to kind of help highlight this, I want to just kind of go through a typical sort of fictional case example. So let's consider we get somebody who's a client who enters into the Veteran Treatment Court. And this is Mr. Z. He's a 31-year-old male, served in the Army, deployed to Iraq in 2007, 2008, and then as well as to Afghanistan in 2008, 2009. Now, a side note, multiple deployments are common, particularly with the OIF, OEF range of veterans. And this is important, too, to always be paying attention to current events and thinking about what was going on. 2007, 2008 was a time of increased hostilities in Iraq, so it would already automatically trigger for me some thoughts I want to think about potential trauma exposure that he had, particularly relating to not just formal, what we think is combat operations, but just run-of-the-mill routine risks and threats that he may have been exposed to. So Mr. Z, in this case, was injured actually during a combat mission and was medically discharged in 2011. We've seen this time and time again. There are no behavioral problems reported in the military history, so this kind of gets aside another whole discussion about reasons for discharge, which I think is a totally valid and important topic to be addressing. So this individual, let's say, gets referred into the Veterans Court, and I'll leave the legal aspects of which and degree and type of charges should be and will be allowed. But let's just say that this is Mr. Z's first arrest. There are multiple charges, some felony level charges, including some weapons charges. The initial reports, at least from the clinical side of things, is we hear that he had displayed a weapon during an altercation at a bar. A bar is important. Evidently, no prior formal history of substance use diagnoses, but that was something we're always going to be testing for. No current mental health diagnoses or medications, at least when this individual is brought into court. Reports to be unemployed and quote-unquote couch surfing for the last 2 years. So in mental health screening, some of the things that kind of come up that would be important to think about would say, we see toxicology screening positive for cannabinoids. Then we go through and there's a positive history of childhood trauma exposure. Evidently, this individual was exposed to combat as well as the general war zone trauma. That's something that I had mentioned. I wanted to kind of distinguish that might be important. I hear this statement time and time again, not only from Vietnam vets, but also veterans from Iraq and Afghanistan. Quote, I was not prepared for what I saw. This individual, let's say, has nightmares, avoids driving, has this exaggerated startle response, disrupted relationships. They can't seem to find or, more importantly, maintain employment because of this anger outbursts and issues. And we'll talk about why I'm talking about all these symptoms, because we're going to crawl through the diagnostic criteria for PTSD in a minute here. The last issue I want to talk about is blackouts. This is a report of he becomes evidently a monster when he drinks alcohol. And we'll talk about why some of those reasons or why some of those things might be happening. General medical review, again, what we like to do, and at least our model is, we like to see everybody sort of all together. They come into our downtown clinic. We're focusing on making sure they have stable housing. They come see a psychiatrist, myself, and then they actually have an appointment right after mine with our Christina Kim, our nurse practitioner, and after that they meet then with our VJA, case manager, social worker. So we have everybody under one roof and see them on a regular basis in this sort of collaborative model. Afterwards, then we meet as a team, discuss the issues, and make referrals and think about treatment planning, and always refining and revising how we're thinking about our individuals. So general medical side of issues, hepatitis screening positive for hepatitis C came back positive, and this is significant. For long-term general health issues, HIV was negative. There are some noted hypertension, mild, didn't require interventions, and some musculoskeletal injuries were noted. And because the pain was reported manageable, the advice was given to kind of avoid opioids, if at all possible. But if that came up in the future, in a typical case, they can be used. Normal vaccines were provided. So does this individual have PTSD? Let's look about it. So with the diagnostic criteria for post-traumatic stress disorder, this is for adults. This is my specialty, and not for children. That has to be direct experience. You have to directly experience some traumatic event or exposure to potential threat of death, serious injury, or you have the possibility of witnessing these same sort of traumatic threat of death events occurring to other people. It doesn't necessarily have to be people you know. However, learning of such events, such as death of family members, there actually has to be an actual threat. So if you learn about it, about your family member either dying or close person to you in your family, has to be an actual threat, not a supposed or possible theoretical. Also, the exposure criteria for PTSD can come from extreme exposure as part of your regular, sort of work, the details of traumatic events. So looking at people who are first responders, veterans, particularly in combat zone exposures, medical personnel. These are all the issues that we need to think about. So usually what we do is crawl through and we're going to go to that in a couple slides, through the different categories and clusters of symptoms you have to have with PTSD. I am moving this little element up to the exclusion criteria because there's some important things in here that might help explain why most people and the majority of people who are exposed to trauma don't go on to develop PTSD, but also there's some important exclusion criteria that are relevant to veterans treatment courts. So the time frame, we need to think about the duration of all of these symptoms that the individual has, not all of them together, not every one. We'll describe the combinations that you can have, but all these symptoms have to be present, and they have to occur together, and they have to be persistent for more than a month. Now, the disturbances, these symptoms, have to disrupt their work, their occupation, the social roles, and some significant area of their lives. I usually take their involvement in the criminal justice system as one of that meets this kind of criteria, since legal issues are a significant area of one's life. Now, I wanted to highlight this. This is probably the most relevant exclusion criteria for veteran treatment court. The symptoms cannot be due to substance use, substance abuse, and it cannot be due to drugs, intoxication state, withdrawal state, or alcohol, intoxication or withdrawal states. It can't be due to medications, it can't be due to general medical condition. What this means is we really have to think about taking time and being careful about making the diagnosis. This is one of the reasons why we actually can't. Now, if we are only going to use selection criteria for individuals with PTSD, we're going to bring in the Veterans Court, well, we might be missing the individuals that basically their PTSD is covered up and can't be made, the diagnosis can't be made because of this exclusion criteria. That's why it's important to talk about that. Now, the reason why we have exclusion criteria is the majority of people and the majority of veterans who are exposed to trauma don't go on to develop PTSD. Post-traumatic stress disorders has been described as sort of this failure of normal recovery mechanisms. The reason why I bring this up is this is exactly sort of the surrounding kind of approach that we're going to take for treating PTSD, where we basically want to bring those recovery mechanisms back online. PTSD symptoms can appear similar to medical conditions as well as substance use disorders, and this is the reason why it's important to have these exclusion criteria. Another thing is, something we often worry about in psychiatry and mental health professions is we don't want to pathologize. We don't want to make a disorder out of everything. And it's normal in some ways to react to trauma in a certain kind of way. And PTSD symptoms have to basically be persistent, and they have to have all these other elements to it, and we're going to go through those now, for it to really meet the level and criteria of what we would say is a disorder. And the last little point on this slide is just a reminder that just because somebody may not meet criteria for PTSD at this time or at other times in their lives doesn't mean at all that their lives are not affected by trauma exposure. So let's just look at now the clusters of symptoms of PTSD. Now the first two, you'll see is you have to have at least one of these two clusters, and then after that, you actually have to have two or more. So it's just at least one for the first two, and then two or more. So this is sort of the re-experiencing criteria. Now, the traumatic event is we have direct exposure. That's the first criteria. We talked a little bit about that. Now, the re-experiencing. Traumatic events now re-experienced by has to be one or more of the following. So recurrent, involuntary, intrusive memories, distressing dreams. We talk about nightmares. And usually it has content and feeling that are similar to the trauma exposure that you had. Sometimes you have this element of dissociation, which is basically the experience of sort of detachment, a sense of sort of being out of one's body, a sense of unreality, distorted or dreamlike experiences. Now you have also two elements which I always look for because it just is very common, are the psychological distress as well as physiologic reactions. And what they are basically the psychological distress. You get emotional responses when you're exposed to triggers. This is the key thing that are important because you have physical responses that are sort of anxiety-like reactions. When exposures to triggers don't necessarily have to be external in the world. They can also be internal triggers. So having the same feelings, having the same thoughts, not having similar sort of somatic as well as the physical injuries sort of experiences, looking at a scar, all of these things can serve as a trigger for developing some of these reactions, and it could be emotional or physical reactions. So avoidance criteria, basically you have constant attempts to avoid memories, situations that begins at, after the trauma, but it kind of also persists then. You're always trying to avoid the memories. You don't want to talk about it. A lot of isolation. Also avoiding feelings relating to trauma. So not feeling fear again, not feeling stressed or strained again. Thinking about also then avoiding environmental triggers. I mentioned that in our case example with Mr. Z. So now we're moving into the criteria. We need to have at least two or more of the symptoms. And this is the aspect where you have negative thinking or kind of mood criteria for post-traumatic stress disorder. One of the things to note, this is where you can start to get some of the crossover between major depressive disorder and post-traumatic stress disorder, which is difficult to sometimes piece apart, but you can do it with repeated evaluations in time and interventions. So this is the aspect where we're thinking about negative changes, where inability to recall aspects of the trauma is actually one of the symptoms. It's actually consistent with a traumatic exposure. Having a lot of negative thoughts about yourself, also having some distorted thinking and negative thinking about your role in the trauma and what caused it and what may have led to it. Also, then we think about these persistent feelings of guilt or anger or negative thoughts that relate to the trauma, begin with the trauma and persist after that. And then there's this feeling of being detached. I often describe it as alienation from other people. And then there's this constant, not quite anhedonia of major depressive disorder, but this impaired and muted ability to feel positive, feel good emotions. So then we have this next sort of little category of this hyperactivity. This is the one we often think of as this hyperadrenaline state. And we're going to talk a little bit about how the model, what I'm describing, is not necessarily sort of hyperadrenaline, even though the stress hormones do play a role. It's actually a little bit closer to what's happening in the brain. But the hyperarousal criteria, we also see you have to have two or more of these. Anger outbursts, aggression, this is often the kind of obvious superficial behavior that we see that may lead to involvement in veteran treatment courts, but also reckless, self-destructive behavior, often reasons for issues relating to being able to comply with treatment. Hypervigilance. It may not be so obvious, but if they're constantly searching the environment, scanning, looking for potential threats, having exaggerated startle response, difficulty focusing and concentrating. This is a direct crossover between two other important symptoms that are often co-occurring with PTSD. Major depressive disorder as well as traumatic brain injury, either mild or full traumatic brain injury. And we'll talk about that, just some of those kind of co-occurring issues a little bit later. So, and then the last thing is just this issue of insomnia, difficulty falling asleep, particularly related to this hyperarousal elevated state. Now, I'm speaking to you from San Francisco, so there's a lot of these sort of Bay Area references and sort of nautical themes, but we have all these kind of criterions, as if we're on one span of the Golden Gate Bridge, looking across the other span, sort of through the fog and mist, which is pretty consistently here, and trying to discern and make sure that we really are seeing the structure, that's kind of peeking out from the clouds, but also what's underneath. And trauma is, in many ways, if you think about this, us as sort of these kind of twines and ropes, this coherent kind of, using the nautical things, rope. And trauma is, in some ways, a tearing of our expectations, a tearing of our emotional realities. And then what we are seeing on the other side, particularly individuals in veterans treatment courts, either judges, attorneys, prosecutors, social workers, we're seeing the frayed kind of ends. And the real question is, each of these sort of strands, how do they kind of come together, and do they make sense of rising to the criteria of PTSD? Well, the reality is there are a lot of different ways in which you can have PTSD, particularly when we move from DSM-4 to DSM-5. They've kind of done some calculations, and there are basically about 636,000 versions or permutations you can have of post-traumatic stress disorder. And the reality clinically is you can cycle through and see somebody within your office that has version 1, version 273, version whatever, and they cycle through. Clinically, what we're doing is we're actually looking for consistency. For just having one all the time is not really what we usually see. We usually see people shifting and cycling through different versions of PTSD. And to be able to do this, to determine which version of PTSD they have and what they're kind of cycling and blending into, and if it responds to emotional reactivity, and most importantly, if they're different from other psychiatric disorders, major depressive disorder, TBI, or some other issues, requires thousands of hours of exposure to people with PTSD, as well as other co-occurring psychiatric disorders in various combinations, and also looking at whether or not PTSD is the driving force behind which behavior. And this is something I'll come back to a little bit later. It really is important to think about the diagnostic criteria and see if it's consistent with the behaviors that we're seeing. If it's not, there might be some other issues going on, particularly co-occurring disorders. So I want to talk a little bit about the brain. I would be remiss if I did not address this issue. PTSD is not an intellectual construct. All right. Now, what I'm about to describe is a model. It's it's hard to explain how simplified in many ways this model is for what I'm about to describe, but I think it's important because this is actually one of the ways that I talk about this consistently with patients who are in the room who have PTSD, and this explains some of the reasons they have for the interventions that I'm going to suggest, as well as the time frame for recovery, the context in which I'm constantly coaching them through this process. So there are some key brain structures, and I'm just going to be very general because getting into the details of the brain structures I don't think is the most important at this time, but there's a couple areas that I do want to highlight, particularly talking about the amygdala. The amygdala is sort of the fear center. It's an area that receives sensory input from the outside and basically looks through the environment to determine whether or not there's something that we should be afraid of. These centers, we have two of them on either side of our brain, our temporal lobes, can be activated. And there's a lot of data and research around like what happens after this activation, particularly when you're exposed to trauma. And so we think back to those two slides about all those different ways in which you can be targeted, as well as the traumatic exposure you can have. Then we have the frontal lobe, frontal part of the brain, the rational thinking, kind of what we describe as executive functions part of the brain. And all these kind of are linked up through this kind of array of emotional circuitry called our limbic system. That's kind of a general overview. So one of the things that's common we see in anxiety disorders, and PTSD used to be considered as sort of an anxiety disorder, but now it's kind of a standalone on its category by itself issue. And this is the next couple of slides are going to explain why that might be the case. Now, one of the things that is common is in anxiety disorders is this amygdala hyperactivity, meaning the fear center is really overactive. And it's been observed actually in PTSD, social anxiety, other anxiety disorders such as panic disorder or phobias. Now, it's not just fear centers that are kind of playing a role here, because we get sensory information in, our brain kind of sends it out to the relevant members of its committee. Now, it sends it to the amygdala. Please look at this information. It's a sound, a creaking floor at nighttime, or something I hear outside. Send it to the amygdala. Is this something that reminds me of the traumas that I was exposed to in the past, a little low-level vibration that I'm feeling in the floor? Then it also sends it to the prefrontal cortex, and that allows that member of the committee is able to kind of say, well, let's just calm down a little bit, let's be rational about what's going on. Also to memory centers, saying, is this consistent with other elements, the things we've seen that we've been exposed to before? And unfortunately, memory centers, particularly the structure is called the hippocampus, are noted to be a little bit less active and smaller in volume in individuals who meet the criteria for diagnosis of PTSD. Now, this is how PTSD may be a little bit different, and PTSD might distinguish itself from other anxieties, but what we see is that there might be some lower level activity, hypoactivity or activation in the prefrontal cortex. That's that part of the brain, remember, that's responsible for rational executive functionings and may be able to serve as a sort of a counterbalance to the amygdala hyperactivity. But in PTSD, you have both. You have this hyperactivity of the fear centers, as well as lower activity within the prefrontal cortex. Now, one of the things that at least some studies are showing is that the degree to which an individual's prefrontal cortex is hypoactive or operating at a lower level might be correlated to symptom severity. Now, we'll talk about some of this teetering kind of balancing model and why substances might play a role in that. I think about alcohol, which is going to be the most common substance of abuse, particularly in individuals with PTSD. It's a central nervous system depressant. And there might be some of these initial sort of depression of sort of all activity, but that may include the fear, that might include some of that anxiety, but also you're going to also depress your ability to rationally and reasonably process sensory input and go through information, think about it, what you're experiencing in a calm manner. Then, therefore, at the same time, impulse control is impaired and damaged. So basically what we're talking about is in the context of like alcohol or a sedative, you have this, you're worsening this sort of imbalance and this tension. And this is the reason why emotional regulation becomes so key, or impaired emotional regulation, because this is the link for veterans being connected up to their behavior in which they would then find themselves in veterans court. Now, just because we have a central nervous system of depressants, some of the more complicated emotions, guilt, shame, horror, existential questions, may not actually be diminished and then are sort of unleashed on a brain that's really kind of struggling to find some balance. So that's kind of the tension we talk about. Now, I just wanted to address that it's not all in the brain. Just because I'm biased as a psychiatrist, there are some hormonal elements, and you hear this all the time, this reports of PTSD is sort of this chronic adrenaline state. Well, yeah, the brain leads the body then down this path of chronically thinking about I'm in a chronic stress state, and this has a cascade effect, hormonal cascade effects, that basically tells the body to constantly feel and have the perception, even though it may not actually be under threat, but that there's a real threat. This creates a chronic hormonal and physical stance that you're under threat and always needing to protect yourself. So this is a little sort of chart about then kind of emotional responses and how this impaired emotional regulation may take place that I kind of made for this talk. Now, let's say there's individuals, and there's individuals who meet criteria for PTSD, individuals who do not meet criteria for PTSD, and then there's a trigger, some sort of trigger, maybe somebody yelling at you, might be a minor car accident, whatever it is. And individuals without PTSD who wouldn't meet the criteria it's a normal response to have a heightened emotional state. Yet we may not get to the point of where it is panic. Individuals with PTSD, because of this emotional regulation impairment, might have the same response and yet be triggered pretty quickly beyond the threshold for basically panic, and then unfortunately persist in that state and have difficulty with basically bringing them down, calming them down because of this impaired emotional regulation based upon the kind of the system we talked a little bit about before. So let's just go through a little bit of some of the numbers, looking at a couple different sets of perspectives. One, looking at the more recently OIF, OEF veterans, then looking at sort of VJO data kind of nationally, and then looking at the San Francisco version to see just kind of how we're consistent with that and sort of in line with some of this data. But generally, about 13% of veterans in some studies, particularly surveying vets in general, not justice-involved vets, but in general, at least have PTSD in some samples. And this is a pretty wide sample, 285. Now, this is just self-report. This is not sort of looking at the data. If you look closer to the data, and if you actually go and selectively interview people, the number is probably going to go up to that range that we saw a few slides ago. Substance abuse disorders can occur, co-occur with PTSD in OIF, OEF vets at a pretty wide range, but up to almost 90% is significant. Now, PTSD and major depressive disorder can co-occur, exist together at a pretty high rate, anywhere from nearly 50 to 60%. Individuals with mild traumatic brain injury who have experienced maybe not loss of consciousness, but a head injury, and particularly in OIF, OEF veterans, really can range from about 10% up to 20% of veterans who have served during this time period. Individuals who are medically evacuated, about a quarter of those individuals have actually had severe brain trauma. So we've heard a lot about in the news, our veterans are surviving much more devastating and significant injuries, not only to their musculoskeletal system, but also to their head and to their brains, and this is significant. Recently, there's been a lot of news looking at soldiers, particularly who have had loss of consciousness, and they've been exposed to sort of blast radius trauma exposures. The data is kind of showing that a significant number of them also then meet criteria for PTSD. And there are some brain changes that may relate to traumatic brain injuries and concussive experiences that might be developing it. Now, the reason why I went through the criteria for PTSD is just because there's, let's say, physical trauma exposure, and we may have this relationship to blast exposure and PTSD, that doesn't mean that there are a lot of other versions of PTSD that do not have anything to do with an explosion. Now, the reason why this is important is that because of all those permutations of PTSD, post-traumatic stress disorder might be actually a heterogeneous disorder with subtypes, and we're really still kind of learning and developing an array. There might be a version of post-traumatic stress disorder that really is related. It's sort of a subtype of PTSD to traumatic brain injury. I will leave that to the researchers to kind of help inform us a little bit about what's happening. So this is the national kind of VJO sort of data and experience. Really the Veteran Justice Outreach Program was kind of started to address homelessness and address untreated mental as well as general medical issues, and to help see if we can get some separation and have decreased frequency of contact between veterans and the criminal justice system because of untreated mental illness. And what we're seeing is, at least with targeting and then through the VJO numbers, is that there are significant numbers of veterans who have mental health disorders of some kind who are being involved in veterans treatment courts. So 90% have a disorder of some kind. Almost 3/4 have at least one mental health disorder, and almost about 70% have a substance use disorder. About 60% have both a mental health disorder. Now, this is sort of artificial, substance use as well as what we consider depression, PTSD. They're all mental health disorders. It just helps kind of highlight the differences between substance use disorder and other psychiatric and mental health diagnoses. Some of the most common mental health diagnoses major depressive disorder. We're talking about sort of the second most common, and focusing in on that, PTSD, particularly because I think as treatment providers, we want to kind of focus in on what we think is the most relevant and contributing issue. What we're seeing as far as the numbers is that nationally about over half, 55% of VGO participants met the criteria for major depressive disorder, and about 37% to 39% met the criteria for PTSD. And then the third in line would be anxiety disorders. And we're very consistent with those numbers, I think, on a national level, about 93%. And again, the idea, the goal for the Veterans Justice Outreach Program was to have a connection to individuals and to get them into care. And what we're seeing was 93% of individuals entered into mental health care for at least 1 year following the outreach visit from a VGO coordinator, VGO social worker, and about 90% of individuals within 1 year engaged in general medical care. So we have mental health care, general medical care, and out of the individuals, at least in the San Francisco version, about 77% at least have one mental health diagnosis, 3/4 of them diagnosed with at least one mental health diagnosis, and then within 1 month they get into, they're seen with a face-to-face encounter. So we have a little bit aging population, sensitive issue for some of us, but about 70% of our patients are 45 and older, and this is consistent with individuals who are also homeless. We have 60% of our patients are also homeless, and this is helpful for us because what's one of our primary goals is to treat and focus in on homelessness. When about 40% are veterans from OIF, OEF time period, and the majority are male. So only 6% of our patients that have come through are female. Now we're talking again in the San Francisco context with our VJO, and the most common mental health disorders are same in line with the national data. About half of the individuals meet criteria for major depressive disorder. The second most common is PTSD with about 37%, and again lower prevalence of anxiety disorders. Now the most common, the reason why I've talked about alcohol a lot is substance use disorders, alcohol, and then a combination of other substances is sort of the next biggest criteria. I was a little surprised at the lower levels of stimulant use in our patient population, but that's the data we're seeing. So just kind of the numbers in review, there's a general sort of baseline level of PTSD in the general population, but it's higher in special populations like refugees, but more importantly for our military veterans. The range for most recent conflicts is estimated from anywhere from 15 up to 35%, I think is the better data, even though we've seen some of the studies that show a little bit lower. And I think that for justice-involved veterans, it's significantly higher. But that's also in line for individuals, for whatever reason, there's a connection. We could talk about some of those socially determined reasons why we have individuals who are exposed to trauma and then also have an involvement in the criminal justice system. And direct experience of trauma is the necessary event, necessary kind of criteria that you need to have, and requires you have each of the major clusters of symptoms for meeting criteria for PTSD, including re-experiencing avoidance, hyperarousal, those negative thoughts and feelings. So what does recovery look like? We talked about some of those nautical themes about the frayed rope and looking at the different permutations. Well, in many ways, what we're doing is we're actually rebraiding that rope. We're actually creating new strands. We're actually tying them sort of back together. And I think this is a good sort of analogy for what is sort of happening in the brain at the neuronal level. So I know there are some clinicians that either are listening or will listen, and I want to just kind of briefly mention kind of just the ability to sort of gauge the severity of the trauma. These are some things I typically am asking, thinking about when is the first experience. This is the development and chronologically is important. What was the duration of sort of each episode, and sort of sometimes I can give me a sense of what was their sort of worst experience and why was it the worst. And what was the frequency of their trauma exposure, whether it is in service, pre-service, or afterwards. All of these are relevant, particularly for individuals who come into us in veterans treatment courts. So I think about then their emotional responses. Again, if you think about it, these are all just sort of questions, topics that highlight the actual criteria. They have nightmares. What are their current triggers? Thinking about all the military-specific questions about, if they've been diagnosed and through VA system in the past, are they service-connected? Significant number of our individuals in the veterans treatment courts are service-connected. And I think about prior treatments for PTSD, and if they haven't been through them, we really think about these are some of the interventions we're going to take on. One of the things I also keep in mind is the global war on terror has really expanded the pervasiveness of the potential threats. So there are no clear front lines, and a lot of our veterans have taken part in intelligence gathering, and sort of the military is involved in sort of counterterrorism. And therefore, exposure to police, and particularly in the criminal justice system, might itself be triggering because it feels very close to home. And when I'm using sort of the clinical, interview techniques, I'm thinking about, trying to have a sense of what I'm going into, so reviewing available history beforehand. I usually preface a lot of the questions sort of with a, some sort of warning. I just want to let you know, I want to ask you about a few things that might be difficult, and I normalize it as well. I usually ask everybody about this. If things get difficult, I redirect questions to less intense, kind of areas of the history that I think are relevant, and then I return to them via a different route. And this is effective with men, and also particularly with veterans. There's a culture of sort of non-disclosure and not being sort of emotionally vulnerable. I always acknowledge the stress of sharing difficult information, because trust and respect is key. And as you're going to see when we talk a little briefly about some of the psychotherapeutic interventions, why this is important. And always closing an interview and thinking about safety, making sure they're always aware of the crisis number and hotline. Now, recovery is sort of individually based. Basically, we talk a lot about this in medical interventions and medications, but really what we're doing is we're kind of handing things off so that individuals really can stabilize and be able to participate in their sort of normal activities, and they have a renewed sense of kind of hope and where they're going. So as I mentioned before, some screening tools are really targeting in then on disorders that we can identify. So we think about, of course, at the top, suicide risk assessment questions. Embedded into our electronic medical record is the PTSD checklist for the DSM-5. The version of that before obviously was the PCL-4. We're all doing homelessness screening, because housing is an intervention that we think about that is just as important as any medication or therapy we can offer, actually probably more so. We, of course, reviewing the substance use criteria, thinking about alcohol use, because it's one of the most widely abused substances that is co-occurring with PTSD. These are the numbers we think about. What are the kind of levels, the acceptable levels for men and women? Thinking about tobacco use for depression, PHQ-2 for initial screening, and 9 for more in-depth screening, and of course post-deployment TBI screening. So we could talk a little bit more. This is sort of a general survey, so I just want to talk about kind of the standard, just general treatments. Back to this evidence-based medicine approach, these are the treatments that are supported by randomized controlled trials. And we have two categories of medications that we found to be effective. Effective in the sense of trying to reduce the severity of symptoms, helping provide some symptom control. So selective serotonin reuptake inhibitors, SSRIs, and a smaller category, a little bit newer, also have been found to be helpful, SNRIs, serotonin norepinephrine acting agents. In addition to these medications, the combination with psychotherapy, basically any trauma-informed psychotherapy, and the key components of that are some degree of sort of exposure. Let's talk about sort of the triggers. Let's talk about the automatic thoughts that come with it, and really focus on sort of a restructuring of our automatic responses to these triggers. Now, the question is often brought up of medication treatment. What about SSRIs and these medications? Well, they have all these terrible side effects, and they can have significant side effects, but usually there's two that I worry about. Initially is the gastrointestinal side effects. It usually starts up early on. Part of the reason is we have such high levels of serotonergic connections in our GI system compared to our central nervous system, which we're trying to target. But then there's the sexual side effects. This is incredibly important for individuals who are in a relationship. This is one of the most common reasons for people to stop the medication and not tell their physician about it. It's a dose-dependent kind of relationship, so the higher the dose, the more likely it would occur. And it's not permanent. Basically, if you reduce the dose, lower the dose, the side effects usually go away. Stop the medication, and everything goes back to normal. But these are some of the reasons that are stopping the medication. And the reality is there are some people who will develop these symptoms, usually a minority of people. Most people can take these medications and not have any of these negative side effects. So that's why there's always this slow, what we call a titration process. Now, this titration process kind of gives you this opportunity. An ideal for using medications to help control these symptoms is to use the least possible dose, controlling all of the symptoms of PTSD, while avoiding, if at all possible, any side effects. If not, really having the minimal side effects. That's the goal. Now, then it gets brought up, well, why are you sort of experimenting on me? Well, the reality is we are in a sort of individualized medicine era. We do not have yet the technology to identify which is the best medication for this individual at this time with their kind of consistent history that's not going to give them side effects. We do not have that data yet. We will, but we're still sort of in the beginning of things. So, in effect, what we're doing is it is like an experiment. We have an hypothesis. Let's say you have PTSD. We are going to test this through screening and clinical interviews, making sure the exclusion criteria are not interfering with that diagnosis. We're then going to intervene. We're going to have therapy, medications. We're going to collect some data, look at about severity, and then we're going to refine our diagnoses, and then we repeat this cycle over and over again. Essentially, it is the scientific method. So, I don't want to be glib about it. It really does make a difference to individuals if you let them know kind of transparently. We don't have the degree of science that really could target things, and we know exactly what's going on. So we do have to be careful. We do have to go through a process. Relating to this is then the use of sedatives and medications. And benzodiazepines, we think about the alprazolam, clonazepam. These are not usually good long-term treatments for post-traumatic stress disorder, exactly for the same reason we talked about this dynamic tension that may in some ways worsen because it's going to shut down those parts of the brains that are necessary for learning and relearning sort of how to bring recovery back online. In general, because of this emotional regulation issue, controlled substances should be used with some caution, especially in cases if there's some history of substance use disorders. Now, I just wanted to highlight particularly, I don't practice individually prolonged exposure therapy. I do refer many of my patients to them, and this is just, I wanted to highlight, the reason why I wanted to talk a little bit about prolonged exposure therapy is just because I want to highlight the core elements that you're going to see that are part of judicial, kind of trauma-informed judicial practice and psychiatric medication and evaluation. There's some core elements that all of us need to be thinking about as we're operating in veterans treatment course. But usually prolonged exposure therapies, about 90-minute sessions, they're time limited, they're structured, and there's a manual sort of goes along with it. There's the key elements as collaborative and therapeutic. They're really focusing on the psychoeducation elements. There's sort of this exposure in developing your ability to tolerate the stress. Think about those internal triggers that we were mentioned before, involving physiologic and psychological sort of reactions. And then really the other element I think is key is just allowing the time and space for processing and providing some emotional context. Now, the question is always brought up, well, what if the individual sort of, they'd go through this and they sort of look worse? Well, should we then be sort of waiting in context? I think most veterans, just like most of the population, actually do not get treatment for their mental health care diagnoses. And if an individual is willing and wants to engage in treatment, they should be, I think, supported in every way possible to participate in any evidence-based intervention. So I do not think that there should be sort of some delay. Now, the mechanisms of how recovery takes place is really sort of this complex, set of kind of mind and biology and the social environment. And we're playing all these different roles, but really the goal is sort of symptom control. We're thinking about not curing. We don't cure because we don't have that level of kind of ability to intervene at this time. We don't cure PTSD, but we can provide some symptom reduction or the reduction in severity of symptoms of PTSD. Basically, our ideas of why providing the structure is to improve your ability to kind of engage in emotional regulation. Basically, so that we can remove the symptoms sort of out of the way and allow for sort of the normal recovery mechanisms and the normal relationships to kind of take over. And really what this is through this process of kind of promoting autonomy and promoting trust, what you're doing is you're actually helping kind of them to generate the positive experiences that eventually will displace a lot of the negative aspects. And the reality is it's a lifelong process. And I have a point on that in a minute. really the goals of the intervention are stabilization of these sort of brain-based sources of damage emotional control. And we talked about this delicate interaction between PTSD and substance use disorder. Substance use disorder, I think, is the controlling key factor here. Substance use has been described as the single greatest predictive factor in the incarceration of veterans. Now, when PTSD improves, you have better substance use outcomes. So that's the main reason why it's important to be talking about this today. Is this is one of those direct sort of conduits. We talk a little bit about those concepts of self-medication, and my version of talking about this is impaired emotional regulation makes you more susceptible to using substances because of this dynamic sort of tension, this imbalance that's kind of set up in the brain. Unfortunately, it doesn't work sort of the other way around. In substance use disorders, if you improve those symptoms, it doesn't necessarily make PTSD symptoms better. And that means that you have to have sort of parallel treatment. You have to treat one disorder kind of in its own right and treat the other one. So instead of sort of, well, you have PTSD and you're self-medicating, so we take care of PTSD and it'll all get better. Yeah, it might help, but we really need to think about parallel and simultaneous sort of treatment interventions. This is sort of the wraparound kind of approach, thinking kind of working from the left-hand side, working in a clockwise fashion. First and foremost, got to have secure, safe housing. Thinking about accurate diagnoses, making sure we know what behaviors are driving which, what diagnoses are driving which behaviors at what point in time. They may change, even in the course of one, episode during court. I usually think about using detoxification of residential treatment facilities based on the severity of their substance use, always thinking about some form of medication-assisted treatment if the individual patient is willing and ready. And that's not just for opioid use disorder, but also, more particularly, I think the underutilized treatment is for alcohol use disorder. So think about short-term, long-term symptom control, longer-term kind of substance use treatment kind of programming, promoting then as we're kind of evolving sort of these healthy behaviors, healthy relationships, meeting legal obligations, and then thinking about some form of supported employment, helping provide and driving purpose forward. So there's some elements that are not in the manuals. They're not in, sort of the official diagnoses that extend beyond the effect of just beyond what PTSD normally is. And this kind of can develop into the combination of personality disorder, substance use, kind of what we describe maybe as a complex trauma sort of situation. There might be elements of moral injury. Was I right? Am I a bad person? Am I somehow broken because of what I've done, seen, or participated in? And these are very subtle things that are talked about this plays into the long-term goal of recovery, of trying to recreate and generate some meaning, because our patients are asking for this. This is, at least from the psychiatric side, this is the kind of thing I get to focus on a daily basis. And this plays a role into like self-identity. What does this mean about me here and now? So I bring this up because I really want to caution individuals about who are treating veterans who've been through these intense experiences about the idea of compassion fatigue or burnout, particularly for family members and communities. This is something we're always kind of training and thinking about in psychiatry, but as you become closer and more sort of intimate with these treatment kind of within this therapeutic jurisprudence model, you're going to be exposed to it, and it's going to have an effect upon you. And this relates to something we call the writing reflex. And this comes from motivational interviewing. We hear about something, and we want to kind of rush in to help. We want to rush in to take away the pain, to make it so that we can do it sort of for them. And there's this writing reflex might drive us to do certain behaviors that might be confusing. Some of the symptomatology, we might be thinking it's PTSD, but it might be substance use disorder that's driving behavior. So I really want to caution you about this writing reflex. The elements of motivational interviewing that are effective with substance use disorder is taking a very non-judgmental approach and allowing the individual to come through their own rational processing to a place where they are committed to making positive change. So again, this is something I want to highlight in these last couple of slides. One of the reasons why I think it's so important to actually be in these pre-conference meetings and in court is oftentimes it is confusing to figure out which disorder is causing which behaviors. and it really does take a lot of time and experience to be able to actually pull them apart and say, well, this is consistent with PTSD, and this is consistent with alcohol use disorder and alcohol withdrawal or major depressive disorder. And this is a really key thing to be thinking about overall. And the one issue I just want to remind is recovery takes it takes an incredibly long time, and this is a lifelong process. And the Veterans Treatment Courts can really provide some of those foundations for recovery. This is you've probably heard about this this is from the SAMHSA model, this trauma-informed judicial practice. Thinking about trauma, you're doing the process by listening to this and watching this talk, being aware of it, thinking about the lasting effects on all these different levels. You think about the social as well as now also the brain-based and emotional elements. Thinking about the quality nature of your communication, the court processes, all of these things can be involved in the calculations for developing PTSD, and thinking about your court environment, providing a calm, professional kind of approach. And of course, this judicial practice, thinking about trauma, doesn't remove individual responsibility. It just sort of more individualizes the interventions that you're going to make, and it helps promote trust, which is one of the things that has been fractured in this relationship. So right before we get to sort of our last slide, in conclusion, we want to talk to our case and what happened. So Mr. Z, let's say, gets referred to combination substance use and PTSD treatment. They get started on medication-assisted treatment for alcohol use disorder, naltrexone, initially an oral version, then converted to injection version. Mr. Z gets into transitional and then stable housing, VA-supported housing. Then after time, the diagnosis of PTSD actually has, really helped promote further engagement. So individual psychotherapy helped work on some of those more subtle aspects we may have talked about, moral injury. And this is kind of run through a combination of coordination of care through the VA Choice Program. Let's say Mr. Z also comes to me and their VA psychiatrist for medication management. Mr. Z also was able to get treatment for hepatitis C, and the virus is cleared. 9 months following graduation from Veterans Treatment Court, Mr. Z actually relapsed on alcohol, but was able to recover with kind of a transient and temporary increasing in the frequency of contact with substance use disorder treatment groups. Following that, we can see that Mr. Z enrolled in college, has ongoing stable relationships and stable housing 2 years post-graduation. Mr. Z still has symptoms of PTSD, but describes still feeling okay. So, in conclusion, I hope that you appreciate that this is a complex topic, and really you've kind of committed already and have some better understanding how trauma is a common characteristic for justice-involved veterans. PTSD, when we went through the criteria, involves direct exposure to serious traumatic events, and then these persistent kind of clusters of symptoms and re-experiencing avoidance, but then also hyperarousal and also negative emotions that come along with that. We briefly went over the standard treatments for PTSD, some aspects, core elements that you see within those treatments, particularly for psychotherapy, but also medications. There's some good medications that are standard that work, do have potential side effects, but it explains sort of the clinical reasoning for basically getting to a level of good symptom control, and the limitations of the science that we have at this point. And one of the things I want to really highlight is that PTSD involves kind of changes in how the brain processes information, even innocuous information. And the other, last element is that veterans, they don't have to meet criteria for PTSD to be affected by trauma. And this is one of those core elements of sort of involving this as part of our regular thinking in our trauma-informed kind of judicial practice. So, with that, I wanted to thank you very much, and I wanted to see if you had any questions.
Well, thank you very much, Dr. Epson, for your presentation, and not only addressing the complexities of PTSD, but some of the complexities associated with addressing PTSD too. So thank you very much. At this point in time, we have about a little less than 20 minutes to take questions. So if you want to use the chat function, I see we have one that just came in. But yeah, any questions, please feel free to ask.
Hi, my name is Tom. I'm a veteran myself. I also work in behavioral health in Louisiana. I'm curious about the testing of hormones. I've seen some work done by Dr. Kirk Parsley with Navy SEALs, and some other work with other doctors addressing measuring hormone production in these veterans presenting with PTSD. and then assessing the various hormonal deficiencies and then treating them to restore their hormone production. And they're seeing pretty good results right now. Is this closer to becoming protocol or prevailing practice?
Well, you know, I think I know what you're referring to as far as looking at the hormonal levels. One of the things, at least from my perspective, is that at least from what I've been able to read, that it's not yet kind of like standard treatment, standard practice, because we don't know if, in general, if the individual being sort of tested are maybe one of those subsets of PTSD, and then for them, they might have an emotional sort of and kind of brain-driven hormonal sort of imbalance. But also, in particular, because especially the model that I've been talking about, our hormonal level and regulation is regulated particularly in, you know, I talked about sort of the sensory input, but also the central nervous system's central kind of output messaging system. That system is being regulated by other kind of committee members, particularly frontal lobe, and it's kind of in coordination with these fear centers. So at least the reason why I've been focusing so much on the brain is that even if you do the hormonal regulation, what that might do is help sort of remove the chronic stress state, allow the brain to sort of settle down and remove some of those, you know, basically somatic kind of constant messages, and kind of break the feedback loop. Now, so the whole hormonal kind of intervention isn't something we do, at least, you know, I don't do necessarily in this practice, but there is something I did want to mention about sort of related to this hormonal thing. There is a medication or a class of medications that we use, particularly related to PTSD-related nightmares, that that basically interferes sort of with this kind of adrenaline response, and those are the prazosin and clonidine. And we use those at nighttime, particularly because what we're trying to do is interfere and interrupt this sort of cyclical kind of feedback loop of, you know, I'm feeling kind of activated and my prefrontal cortex is not as active during sleep, but I'm still have my fear centers are still kind of running and charge ahead. That's the closest we have, at least for some good indications for interrupting the hormonal cycles. That being said, you know, I often encourage like a pretty broad approach. So thinking about good balanced diet, exercise, all of those interventions, actually, particularly regular exercise, it's actually more effective than a lot of the medications that I'm able to produce, you know, or able to provide. So I really focus on the healthy living, healthy lifestyles, particularly because we've seen those sort of comprehensive interactions having, I think, pretty good effects also on those hormonal levels. That's a great question.
Yeah, thank you for your question, Mr. Jarlach. I have another question from Mr. Seth Levy. He asks, is there a relationship between the length of time after the traumatic event happens and the treatment begins with successful recovery?
It's a good question, particularly because I've seen all kinds of responses. So one of the ideas is that if we have immediate sort of interventions, we can sort of prevent PTSD from happening. The problem is there's a subtype of PTSD that can be kind of delayed onset, and it doesn't necessarily have to occur as far as close in proximity in time. And this is the reason why is, so remember how we talked about some of those brain structures, how they sort of emotionally just process information. They don't also necessarily have especially the really strong emotional centers like the amygdala, they don't have a really good, clear sense of time. That's our frontal lobe, rational kind of thing. That was then, this is now. That sort of arrangement in time doesn't necessarily happen on an emotional level. So, you know, unfortunately, I've seen all types and all degrees of severity of PTSD that can be well extended and well removed from the time of the trauma exposure. Now, the important thing to that is what's been happening in between that time. This gets into the whole issue of co-occurring disorders, particularly if there's been a significant amount of time. We're rational creatures, we're problem-solving creatures, we're trying to help ourselves feel better. So the issues that I run into are what's been occurring since then, and this has happened in a few of my patients I've seen here in the last couple of months. Unfortunately, what's happened between the sort of trauma exposure and the time I get them is a lot of co-occurring substance use. And it doesn't matter if it's alcohol or some other sedative or stimulants, then in some ways that kind of tells me there's a degree of emotional regulation that we need to focus in on, but also an additional line, an additional set of problems that we need to address. So,
thank you, Mr. Levy, for that question. Thank you very much. Just as a reminder to everyone, I saw a couple of people jumped on the webinar a little late, and if a few more people have to leave early, we are archiving this webinar, and it'll be made available on our website and on YouTube. Once it's available, we'll make that link available to you all. So we have about 10 more minutes left for questions. If anyone else has a question, feel free to ask now.
Just wanted to bring up one thing, if I could. Just one of the things that was posed in the last question is the idea of successful recovery. Recovery model, just the same as a recovery model with substance use disorder, I think it helps inform us in thinking about our approach to recovery model for post-traumatic stress disorder. There's going to be sort of this undulation of symptoms, and there's going to be sort of the ebb and flow. Therefore, the idea of recovery is to not remove these symptoms from occurring ever. It's just in many ways allowing so these symptoms can sort of be managed and persist while the rest of life is able to kind of carry on. So therefore, when we have future stressors, when we have future issues happen, because life will kind of continue on. We're going to have loss. We're going to have other things that are going to stress our systems. The idea is for successful recovery, at least I thinking about, is really kind of going through that learning process. This is, like, again, I cannot stress how long it takes to going about constantly, in many ways, learning how to manage these stressors, how to incorporate, and I guess we could talk about learn from them. And I'm not saying learn necessarily from trauma, but I'm saying learn about our own recovery mechanisms that, for whatever reason, we survived our trauma exposures. Now, what we need to do is we need to think about adding new tools to this, to the toolbox. So, successful recovery is a process. It really is sort of the journey, and you're not necessarily going to sort of get there. You're always actually going to be sort of in processing, in transit. And it's a little vague, I know it's a little abstract, but it's one of the, I think, key things. And I really like that you talked about recovery and what that might entail.
Mr. Levy also has a follow-up question. He asks, is there a physiological change in the brain from the traumatic exposure, and can that change be corrected?
So there are a lot of theories about what's happening in the brain. Some theories are that the amygdalas, those fear centers, are activated, and those same neural networks are then kind of, it's sort of locked in those neural circuits. Some research is showing that there's actually impaired connectivity, particularly if you've been exposed to trauma as a child and it persists into adulthood, and that even low-level severity. I mentioned that. There's one of the articles that talks about the proceedings of the National Academy of Sciences that talk about kind of childhood treatment and how that can persist. So there's a lot of ideas how that can happen. The good thing is that the brain is actually relatively plastic. So the reason that I talk about the idea of positive experiences sort of displacing sort of the negative symptoms and then these negative sort of brain imprints of PTSD is just that. And actually what happens is by going through medications and going through good development, kind of trusting yourself, going through this kind of process of therapy, rebuilding relationships, and meeting your legal obligations, what happens is you essentially create the environment in which your brain is able to kind of go back to what its new normal is going to be. Now, again, this is theory. We haven't gotten to the point where we're able to kind of put you into a scanner, look at your level of degree of kind of interconnectivity, give the interventions that we think are going to be most targeted based upon your degree of brain impairment, and then see afterwards. But that's probably where we're going. That's probably where the science is leading us, is that we are going to be able to see, some, particularly related to interconnectivity, which parts of the brains are connected and how they're sort of communicating based upon kind of sensory input. particularly related to emotional regulation, the ability to kind of manage through emotionally difficult situations and scenarios. So in many ways, what we can show is that they can sort of be corrected. They may never go back to sort of normal, and that's what I talk about. That's why I was mentioning sort of this abstract concept of recovery. Everything I'm mentioning sort of as a concept has sort of a correlate in the brain and how it works, especially relating to the environment and with itself, most importantly. Great question, though.
Thank you, Mr. Levy. About 7 more minutes for questions. Anyone else? I guess I'll go ahead and ask a question, Dr. Epson. I guess in terms of addressing PTSD, is there I guess, systematically speaking, in terms of addressing the different types of PTSD that might be present in terms of a veteran that is coming back with obviously the wounds of war, but some of those underlying issues that they may have experienced trauma growing up. All types of different trauma growing up, and then also the additional trauma that they may experience just with being justice system involved. In terms of your treatment, is there a way that to systematically go about addressing that?
So usually what I do is try to separate things out as much as possible as far as try to identify, let's say, trauma exposure, if it was early childhood, if it was neglect, abuse, violence, focus in on some of those emotional regulation issues that might be consistent with somebody who only was exposed to that type of trauma. And then focus in on maybe some other interventions that might be more targeted to military exposure, particularly, let's say, group settings for, veterans who have been exposed to trauma. So I might kind of have a more targeted treatment for that approach. For some kind of persistent sort of physiologic and emotional symptoms, if they feel sort of too much overwhelming, then I'll kind of add in medications. What I'm trying to do is trying to target basically, following the lead of an individual, because everyone is going to be sort of different. So what I try to do is really figure out, okay, what's the role of substance use? Is that playing some sort of role in your degree of emotional regulation? Of that, I'm going to focus more heavily on the emotional regulation aspect of substance use disorder. And then, simultaneously, in the background, just kind of being like, let's start working on your ability to kind of trust and develop relationships or process your own information. So I might then refer them to cognitive behavioral therapy in addition to adding some medications to help with that emotional regulation process. And that's what I'm thinking about. Basically, I'm going to be exposing my patients, especially if they're ready and they're willing, to difficult memories, difficult thoughts, and I want to not only prepare them, but also to help, in some ways, sort of inoculate them. I want them to be able to, in some ways, tolerate the stress and strain, and help them adjust, particularly their expectations, and saying, this is going to be a beginning process. I see people all the time who've either never talked about their trauma, they have never been diagnosed with PTSD, and they've never really engaged in therapy or treatment of any kind. So, especially with the Veterans Court context, I really cannot stress how it's just the beginning. In our Veterans Court, we have people in the Veterans Treatment Court initially for a 2-year period. That's what I really consider as an introductory period. So I'm really kind of going through this process over the 2 years, meeting with them, trying to figure out where do you fit best sort of in the system, and then kind of adjusting and meeting them wherever they're at. So if their symptoms are so severe and they have sort of this polytrauma relating to childhood abuse and then their exposure to trauma in the service, I then think about, based on the severity of symptoms, whether or not they need residential treatment, or if we can manage this sort of in the outpatient setting. So I'm always trying to target those symptoms. And again, if it's going to be traumatic brain injury related, I'm going to send them to a specialized traumatic brain injury kind of rehabilitation clinic, in addition to the combat exposure kind of group settings, in addition to substance use treatment. So we're really kind of, the great thing about the Veterans Administration is there are so many resources and so many subspecialty areas that can really target treatment to these individuals. So I don't mean to go on about that, but that's kind of how it works. It really does follow the lead of the individual, follow the lead of the patient wherever they're at. Because again, you can find somebody who seems sort of stable for the first year and a half, but really then starts to unravel in certain kind of ways, maybe because the circumstances have changed, life happens.
Absolutely. Thank you. Thank you. So we have about 2 minutes. I don't want to exclude anybody if anyone has any questions. If anybody, has any questions afterwards, feel free to contact, like I said earlier, either Kiera or myself. We can follow up with Dr. Epson. If there's any other resources out there that you may need, I know Kiera and myself can also provide those also. So, any more questions in the last couple of minutes? Well, all right. Well, I would like to thank you all for joining us today on this webinar with Dr. Epson. As I said earlier, please feel free to follow up with myself. I think somewhere my email is probably displayed. If not, we'll send it out through our Justice email. But feel free to contact me if you have any other questions, and also check out our other webinars, our Veterans Treatment Court series. So with that, thank you, Dr. Epson, and thank you all for joining, and have a great rest of the day. So thank you.
Thank you all.